So, welcome everybody. Welcome to another EANS webinar, again from the CSF section of the EANS. And we have a super interesting topic today. We are talking about endoscopy for intraventricular pathologies. And it is your webinar, so please feel free to type in questions in the Q&A sections and to take part in the discussion. And we have two wonderful superstar speakers. We have Pathology from London, UK, and we have Henry Schröder from Greifswald, Germany, giving two talks. And we will have discussions after each talk and a little discussion in the end together with all speakers. I come right to the point and very briefly introduce Professor Henry Schröder. He needs no introduction. He just the key steps. He is director and chair of the Department of Neurosurgery in Greifswald, Germany since 2003. He is the board of the International Federation of Neuroendoscopy, in the German Society of Skull-Base Surgery, in the WFNS, in the German Academy of Neurosurgery, and he's also the chairman of neuroendoscopy of the WFNS and president of the International Federation of Neuroendoscopy for several years. He's very well known. He is, and I personally know that, a super skilled surgeon. And I'm very happy to give this short introduction. I now hand over to Mansur Foroughi to guide us to this webinar, please.
Thank you very much, Jürgen. Welcome to all the participants, all the attendees in the panel. I'll first start saying thank you to Professor Jürgen Beck, the chair of the CSF section, for doing so much to keep the brilliant momentum going of this group and this section. And also to Katharina Wolf, both of them have been doing so much to keep developing this field very, very well indeed. Welcome to all the attendees, and of course, welcome to Henry and Basil. Just a little reminder for all the attendees that after, when you're listening, if you have any questions, please put your questions in the Q&A section, not in the chat section, and you will have opportunity to be heard. And we'll try and get as many people heard as possible. Welcome to everybody from all around the world. I think we're going to start with Henry. Henry, welcome to you, and wonderful to see you back in this platform. Thank you.
Yeah, dear Jürgen, dear Mansur, dear Bas, great pleasure to be with you together, ladies and gentlemen. I should talk a little bit about my experience in intraventricular neuroendoscopy. I hope this is moving. Working?
Indeed,
good.
Yes, that's fine.
So today, I don't want to give you evidence-based medicine, make no literature review, but I just want to give you some advices how I do intraventricular endoscopy, my personal experience. Every other stuff you can read in PubMed. So when we work in the ventricles, we have the problem that we have not an air-filled cavity, but an CSF-filled cavity. So we have underwater surgery. So we can do endoscopy in all compartments of the ventricular system, but especially if it's dilated. So hydrocephalus is, of course, an ideal environment to perform endoscopy. Underwater surgery means that when you have anything in the CSF which blurs the view, like CSF or protein-rich fluid, then you have a problem with visualization. And this has to be overcome with some tricks. So I use a lot of ventriculoscope. There are different sizes, a bigger one and a smaller one. We used also flexible endoscopy for a while, but the image quality was not good because of the pixels, but we used it to inspect the aqueduct or go to the temporal horn when we have a precoronal borehole. Nowadays, there is chip-on-the-tip technology available, but we in Germany and in all of Europe, we have this strong regulations, sterilization regulations, that all endoscopes which go to the brain must be autoclavable. And that's why we have not a flexible scope officially released for brain surgery in Germany. That's so far. That's very pity, because I have seen a lot of nice videos from America, from Asia, where you can have really nice image quality with a flexible scope. Hopefully this will change in the future. But in most of the instances, I think the rigid endoscope is better because the optical quality is still better. It's an easy guidance and orientation. When the camera is oriented in the right way, It's very easy to go through the ventricular system. It's much more difficult with the flexible one. And we have a large working channel and are much more effective, even in taking biopsies. And we have very large effective surgical instruments. The disadvantage is, of course, we cannot work around the corner. We can look around the corner with angulated scopes, but we cannot work around the corner. That is still some is a field where we have to do some more developments. But because of the new medical device regulation, all companies have not so much money to invest in research. They just want to have certified their old products. That's a little bit a pity. So for me, it's very important that the ventricular scope has an endoscopic sheath. This can be used also for dissection to create room for hemostasis. I will show you some examples. So at first, the trocar goes into the endoscopic sheath. We puncture the cavity, ventricle or cyst, and then trocar is removed and the endoscope comes in. So the endoscopic sheath has a lot of advantages. What you can do with it is you can use it as a retractor to create a working space for hemostasis. So for me, it's very important to have it, and I don't like to have this peel away sheath, which some surgeons prefer. For example, here is a choroid cyst resection. Here's a fornix. So I go in with my endoscopic sheath, and then I can retract the fornix, and I have the lesion in my view and can dissect it under perfect visualization. Just one example. What I also like to use is an optical trocar. So optical trocar is a conical shaped trocar with an endoscope inside, so you can see where you go. For example, when you have a small foramen of Monro and you want to dilate it, it can be ideally done with this technique. So this was a young guy with a hypothalamic hamartoma, and you see the foramen is almost closed by a very thick thalamostriate vein, choroid plexus. It's a very, very small foramen. When I go in with my endoscopic sheath, I will damage it. That's why I make first a foraminoplasty to dilate the foramen a little bit. And then I take this optical trocar, which dilates the foramen because of the conical shape of the tip. And then you can go in and you see here, this is the hamartoma. And this can then be disconnected. And when I go out, you see there's no damage to the fornix or veins. So this optical trocar is ideal to dilate the foramen of Monro a little bit. Of course, when it's very small and you try to dilate it with this endoscopic trocar, then of course it will also cause damage. But if it's just 1 or 2 millimeters less in size what you need, then it's an ideal tool. For me, important is to have a large working channel. This is a 2.9 millimeter working channel in the laparoscope, which is very helpful for resecting of tumors or also for resecting of colloid cysts. And the endoscopic sheath has an outer marcation of the length, so you cannot inadvertently go too deep into the ventricular system. Because I have been expert witness for a case where they really hit the frontal skull base, and you see it on the MRI. And this should not happen when you have a marcation of the length, and you know in 5 millimeter depths, you should hit the ventricles. You can go to 6, but not more. I like to have the endoscope fixed for intraventricular endoscopy and a mechanical holding arm. This is a pneumatic arm, Mitaka. It's a point setter, it's called, and it's very nice because you fix it, and then you can have both hands free for inflation of a balloon or for take suction when you want to evacuate a colloid cyst. Of course, when you have an experienced assistant surgeon, then it's also good. He can hold the endoscope, but in the ventricular system, it's different to the nose. In the nose, you can move, nothing happens, but in the ventricular system, if you have a small foramen of Monro and you are in the third ventricle, and your assistant is not taking care and move it, even some millimeters, this may cause severe damage to fornix or veins. And then you can loosen this screw, and then you can turn the endoscope 360 degrees in the endoscopic sheath, which is also an important feature. Then there's a smaller variation of the laparoscope, which has the same equipment. And this is used for ETV, for biopsies in small ventricles, or for septostomies. And also the length marcation is there, of course. And you here see the difference. The main difference is the optics. This is 1.7 millimeter. This is 1.2 millimeters. And although both are rigid rodlet scopes. When you take the same camera, you see the larger Lotte has, of course, a better optical resolution, but still the little Lotte has a good image quality when you compare it to other fiber scopes, which have the same diameter. HD camera is very important. I'm still a fan of the HD camera. I like it more than the 4K because I think the color fidelity of this camera is really still better. But this is my personal experience. And you see, when you go very close with the endoscope, you can even see erythrocytes running through the vessels. This is the image quality what you get with an endoscope, Hopkins 2 optic, and an HD camera. Now, of course, we have different angles of view. We have 0, 30, 45, and 70. And you can look nicely around the ventricular system. You see this is a fornix ipsilateral. This is a fornix on the contralateral side. This is a 45-degree endoscope visualized. And in between the fornices, you see here, this is the anterior commissure. So the anterior commissure connects both fornices. This is the lamina terminalis. You see the chiasm. And over the chiasm, you see a tumor seeding of a medulloblastoma. And you see also here is a medulloblastoma seeding in this patient. When we turn 45-degree endoscope backwards and we just turn it, we don't move it, we don't tilt it, so no damage, we can look the posterior part of the third ventricle with the posterior commissure, habenucar commissure, pineal recess, and the entrance into the aqueduct. This is all visible just by rotating the scope. It's like a radar view. It's not tilting that you damage it. Then we have, of course, different instruments. For me, very important is that the scissor is sharp pointed and one branch is fixed. There are also scissors where you have both branches moving, and it's much more difficult when you go close to the basilar, want to cut an arachnoid fiber, then it's better one branch is fixed and you have to only take care about the one which is moving. And all these instruments have a length marcation, so you can go quickly into the system. And when this length marcation is here at the entrance of the funnel-shaped entry port, then the instrument is just at the beginning of your endoscope, and you can bring it under control in the surgical field. We have also a guillotine knife, which is, I think, useful because you can go with membranes under the membranes and you cut, and you have not the damage what you have with scissors. This is an arachnoid cyst and it's a regular scissor, and here below is an artery. And you see, I want to cut the arachnoid, but it's always difficult. I have to puncture it, and I come very close with the membrane to the artery, which is then endangered. So it's better with the guillotine knife. You go under this membrane, and then the knife comes from above, and you can open it, and so you can make a cut along the artery without the risk of damaging it. Hemostasis. Hemostasis is very important, of course, in intraventricular endoscopy because we are underwater, and there are different techniques. What we use for hemostasis is a bipolar forceps and a bipolar diathermy rod. Both are effective. Irrigation, we use just a syringe per hand. And this is a suction catheter, which we sometimes use to remove bloody CSF from the ventricle. You see, this is the bipolar forceps. It's very effective. For example, coagulation of the choral plexus. This is an area. This is a colloid cyst below. You can coagulate it. Another technique when you cannot have a sufficient hemostasis because the tip of your bipolar instrument is sticky, and always when you bring it away from the vessel, it ruptures again. This is balloon compression. This is a bleeding during the resection of an ependymoma at the posterior commissure. And you see here is a vessel in the posterior commissure which bleeds. And I tried to coagulate, but it was always sticky and I could not get hemostasis. So what you can do is you take a Fogarty balloon catheter, inflate it, you make a compression of this vessel. Then I hold it for 5 minutes. And after 5 minutes, you release the pressure. And then usually the hemostasis stops. And you can go out and you see nothing happens, no damage to the posterior commissure, aqueduct looks good, and no hemorrhage. So balloon compression is one variation. Another variation is a small chamber irrigation technique. This term was coined by one of our fellows, Jotham and Waring. He said, we can term this small chamber irrigation technique. It means when it starts to bleed, you don't see much. You start with irrigation. Then you get a glimpse of the bleeding point. You go slowly closer to it. Then we create a small chamber. That means I go with my endoscope into the sheath and I create this chamber. Because it's very small, you always get it clear. And when you go very close with the endoscopic sheath to the bleeding point, you have good control and you can get hemostasis under direct visualization. One example is a colloid cyst. You see by manual technique, I pull the cyst out, but there's an artery from the telechoroidea very adherent to the cyst capsule. So I take care and I coagulate it really several times, this artery, to make it ready for cutting with scissors. So I coagulate several times and then you see I cut too far proximally, so it still starts to bleed. And you see, although it's a very small artery, immediately the vision get blurred. So I release the cyst, start my irrigation, and then I go very close with my endoscopic sheath. And then, of course, you have to be careful that you do not damage structures with the margin of the sheath. So you have to see a little bit, otherwise you should not move. If you don't see, don't move the endoscope. But here I have a glimpse of the structures. I start irrigation, and then I go a little bit into the sheath. You see, now I see my sheath here, and I see, aha, there's a telechoroidea. So I retract the fornix a little bit, so I can get contact between my bipolar diathermy rod and the telechoroidea here. And then I can coagulate, and I don't need to interrupt the procedure, or I don't need to switch to microsurgery in this case. And then I continue with my irrigation. It's a very helpful technique, in my opinion. Another technique, when you have severe venous hemorrhage or arterial hemorrhage, is a dry field technique. Dry field technique was first described in 2002 in colloid cyst resection, and later on Joachim Oertel put 6 cases together. So the indication is always a hemorrhage which cannot be controlled with short-time irrigation. You see, this was a miscommunication between me and my assistant. He should just rotate the scope, but he pulled, and you see, boff. Japanese flag is coming, and you know, now it's difficult to get hemostasis with irrigation and coagulation. So that's why I don't wait very long. I took just the suction tube, or the main channel, and then carefully I removed the bloody CSF by suction. Of course, you have to be careful that you don't touch here anything, that you do not damage veins or fornix. So I remove all the bloody CSF. And it's interesting, in all cases where I did this technique, the hemostasis stopped just by removing CSF. So I never had to coagulate the vessel, which was the origin of the bleeding. Just by removing CSF, the bleeding stopped. And then I continued with the surgery. And you see here, after irrigation, fornix is intact and the bleeding stopped completely. And this is after resection of the colloid cyst. You see no damage to the fornix. So these are technical tricks for hemostasis. I like to have bimanual dissection. So I have a flexible forceps that goes via the side channel, and the main instrument comes via the main channel. It's a straight instrument, so I can grasp a cyst, for example, and I cut and have no risk. I cut to the fornix because I elevate it. This is also helpful in many instances. This is our pneumatic holding arm. You just need to press this golden button and then you can adjust it. So with the left hand, it's very important. With the left hand, you guide the scope in, out, left, right. With the right hand, you hold the instrument. You can go only in and out. When you watch people, you always see they try to bend the instrument to go left, right, but it's not working because you have this rigid working channel. So only with the left hand, you guide it, and with the right hand, you go only in and out and open and close the forceps. Neural navigation can be easily adapted to the system. It's very helpful when you have small ventricles, when you have an approach which is not the regular Kocher's point or so, the navigation is very helpful. This is our setup in the surgical room. Before you start with any endoscopy, you need to understand the anatomy. It's very important that you look at the MR images. And we have different sequences. For example, we always make a flow sequence in hydrocephalus cases as an inversion recovery tubus spin echo. And you should see a black signal as a flow void. But here you don't see it. On the other side, this is a cis sequence, it's a high resolution T2 weighted image, and you see bulging of the lamina terminalis, bulging of the floor, pre-stenotic dilation of the aqueduct, so all signs of occlusive hydrocephalus. So these sequences are very helpful for MR imaging. So what are indications for intraventricular endoscopy? Any type of occlusive hydrocephalus, tumors, choroid cysts, arachnoid cysts, painous cysts, interparenchymal cysts. All these can be addressed very nicely with endoscopy. What is very important, you should really look precisely to the MRI to plan the approach. When you make microsurgery and you have a bigger flap, you can look from this angle, from here, but endoscopy, you have one borehole, one trajectory. And this is very important that you take care. You see here, there is a dilation of the third ventricle. There is tumor in the aqueduct. So the aim is make an ETV, get the biopsy. Two trajectories. Can I do this from one borehole? Where I have to look? I have to look to the foramen of Monroe. And this is frequently not done. This small, very small foramen, you can come with this rigid one, make an ETV, but we have to make the borehole far anteriorly, exactly in front of the coronary suture. Then you cannot reach the other one. If you take in this case just one borehole and try to gain access to both regions, you will destroy the fornix for sure. So when you have this, you make straight approach for the ETV, takes a flexible for the biopsy, or you need to make two boreholes when you have not a flexible scope. That is very important. So the foramen of Monroe is very variable. Sometimes it's really large, you get access to the floor easily and to the aqueduct, and sometimes very small, and then it's very difficult. And this has to be seen before. One example, this is a lady we just get in our clinic some weeks ago. You see a big pineal tumor, and you see there is also a lesion at the infundibulum. So we want to make an ETV to treat the hydrocephalus, and we want to get a biopsy. Can this be done from one approach? For these cases, endoscopy is very important. So I plan the approach here to the ETV. I just go in the front of the foramen of Monroe. I can reach it. Takes another one. I can get here. And then I put the approach which enables this trajectory to this region and to this region without much manipulation of the fornix. A little bit you can move the fornix, but not too much. So the entry point is not at the coronal suture, it's not at the hairline, it's just in between, let's say 2.5 centimeters in front of the coronal sutures. So an intermediate borehole for both locations, and then I can get access here. So that is my trajectory where I aim to. And you see, we go in with navigation. This is the foramen of Monroe, and I see a little bit of the floor, and I see a little bit of the dilated aqueduct. With a 45-degree endoscope, I can see very nicely the tumor. And here you see the metastasis and the infundibulum. So at first we do the ETV, regular fashion, take a balloon, look in, all looks good. Then I tilt the endoscope backwards, you see? Now I see the tumor here, and then there is a trick. The working channel is in the upper part of the endoscope. When I want to take a biopsy, I have to tilt a lot. But what I can do now, I rotate the endoscope 180 degrees, then the working channel is down, and the access to the tumor is earlier. That means I don't need to tilt the endoscope so much. And that is done in this case. So I look, here, no damage to the veins, all is good. This is a mesenteric intermediate. This can be cut or just pushed backwards. And now you see, I turn the endoscope 180 degrees, that my working channel comes down. And then I see my forceps down, and I don't need to tilt the endoscope so much. So it's a small trick, but very efficient, especially if the foramen of Monroe is a little bit small, that you don't do any harm. Then we take the biopsy. And I just wanted to show you the result, that you believe me that the foramen of Monroe is not damaged. It's very important that you really look to the size of the foramen. So there are a lot of techniques for restoration of pathways: septostomy, foraminoplasty, ventriculostomy, aqueductoplasty, stenting. We have not too much time, so I just talk a little bit of ETV. The borehole, most cases, is done in front of the coronary suture. Of course, you can also use navigation for all these cases. We don't do it, but there are arguments to do it because then you are really safe, especially if you have not much experience. Typically, what you want to see is the mammillary bodies, infundibular recess, and then you go just in midline, halfway between both structures. And then you should be just behind the clivus. This is the ideal point. Balloon, Liliequist membrane should be open, very important. If you don't do it, it's a problem. The floor may look very different. Ideal, it's like this, translucent. You see the clivus here, infundibular recess, mammillary bodies, so you make the hole here. That's an easy case. Sometimes you see the PCOM is running through your surgical field. Then you go a little bit more to the side. Sometimes it's not translucent. Then you look to the MRI on the sagittal plane to see where is the basilar, and you make the frame, the ventriculostomy here just in the midline, in front. You should always go in front of the basilar, even if the floor seems to be more thin behind the basilar, because behind are the perforators going to the midbrain. When you rupture one of these perforators, it's a disaster. So always stay in front. You see here, the floor is like an arachnoid cyst, went 1 or 2 centimeters down the clivus and goes up. In this case, you don't open here. You just go here to the clivus and make an opening here, and then the floor comes up and starts to pulsate. Here again, fetal origin, the posterior cerebral artery running through the floor. Of course, then you have to adapt, go a little bit more to the side. So it's very important that you take these into account. Just one example, you see typical case, tectal glioma, chronic hydrocephalus, very thin floor. It starts also already to pulsate. You open it with the deck forceps, then you inflate the balloon. Very important that the Liliequist membrane is open as well. It's very important. Then you should see the basilar. It's always requested that you see the basilar. That is very important. Sometimes you have a lot of membranes here, and then you go down, you make the opening, but then I follow with my endoscope when there's enough space between the basilar and the clivus. I open all these membranes, and therefore I use the little lotter because the little lotter can fit through your ventriculostomy side. You see, and there are thick membranes. I cut with scissors, and then I go again one layer deeper, and there's another membrane. This is a basilar, this is a clivus, and you see another thick membrane. Also, this has to be opened. So sometimes you can follow when there is enough space in front of the brainstem along the clivus and open all these membranes. Or if you don't open these membranes, then there's a higher risk of failure, of course, because there's no pulsatile flow. And then when we look down, you see here, the abducens nerve comes into view, and then there are no membranes anymore. This is a case which underwent 3 times at another institution an ETV. And then he came to us, and you see the floor is again occluded. It's an aqueductal stenosis. And when you see there is a lot of membranes, it was after tumor resection. So I take again scissors, and I cut all these membranes along the clivus until I can see a free subarachnoid space in front of the brainstem. And then we take an endoscope, looking down. You see now here again, there is an abducens nerve. It's very important that this is all open. Otherwise, the ETV will fail. And one last case I want to show you. This is also a redo ETV, patient with an aqueductal stenosis. You see, I feel here the clivus, very thick membrane. So I open close to the clivus, open it, take a Fogarty balloon, and then what I want to see is a basilar. And I go in here, what you see? No basilar. You see, this is the arachnoid. So this will not work. This is the subdural space. And then, of course, this should be open. It's, of course, a little bit difficult because you see the basilar is here. So I push the floor a little bit down. Then I take scissors and I open this membrane, and then I get a communication into the subarachnoid space. I think this is very important. Okay, I think I stop here, otherwise I talk too long. Thank you for your attention, and if there are any questions, I'm happy to answer.
Henry, that was brilliant. There are many questions, and I have to say there's lots and lots of compliments you can see on the screen from all the hands and the heart signs. Before I ask the questions which have been placed, I have to say, listening to your talk, there's a saying that from Oscar Wilde said, experience is a question of instinct about life. And when I listen to this, it's like I'm reliving my first 10 years, 12 years in neurosurgery in some ways, but I'm learning still what I'm watching, what I'm listening to. And it's so important for everyone to learn from the masters and to listen about what not to do and what to do, and to listen to these principles. So I think there's some brilliant gems there, really. One of the questions already been put forward by Giovanni is, have you ever observed any amnesia due to damage of the fornix when dilating the foramen of Monro? Because we saw that beautiful technique with the balloon and then the probe that you used to dilate. But if you could talk a bit about that.
No, this I have never observed because I don't dilate much. You see, when you see that the foramen is very small and you have just the larger lotta, then of course you should not go through. You should take a smaller one or you don't go. What we observed in the early cases of a colloid cyst, where the fornix was very thin and I resected it and the fornix was damaged by the resection, there we had a memory problem. But simply by dilation, no, it's not the case. But as I said, you dilate, let's say 1 millimeter that you slide in, maybe 1.5, but not 3 or 5. Then of course you rupture the fibers.
Fantastic, thank you. Next question is from Rodrigo regarding, is there a personal algorithm that you employ for using either an open interhemispheric approach versus endoscopy technique for removing a colloid cyst? I have to say, this sounds like an important question in the sense that perhaps do you do all of them endoscopically, or do you do mixed? And is there some formula that you use? Or
no, there is a lot of parameters. Of course, I tried to use an endoscope, but with my experience now, I see cases I know this will not work well. Of course, you can try and to force it, but I think it must be the safest technique for the patient. Maybe we make another webinar about colloid cysts and I can explain. So when I see that the foramen of Monro is very small and the cyst is a black cyst in T2, then I know it will be a mess going transforaminal. Then I should come transeptal, come from above. And if it's very firm contact, the cyst is large, and microsurgery is much better because also safe technique, you have bimanual dissection. So that is very important. Also, I look, is there a septum in the cavum pellucidum? That means the fornices are separated. Then an interfornicele is ideal. When I see that the fornix is one structure, which is frequently the case, I would never go interfornicele because you will damage your fornix for sure. So many factors which you have to take into consideration.
Brilliant. I really do hope we see the book on tips and tricks for neuroendoscopy, because what you've just mentioned, these kind of things are just not in the papers or the literature. And it really becomes.
There is a nice book about colloid cysts coming out right now. This is a good recommendation if you want to be informed about colloid cysts.
No, wonderful. Thank you. Now we've got another question about hemostasis technique for ballooning. Won't it make the cerebral arteries more prone to small aneurysms because it can cause severe pressure on the vessel? I suppose what he's asking Miranda is there any risk of dissection of the vessel by any direct pressure?
No, there's only small vessels. As when there is a major vessel bleeding, then the balloon technique is not working. But these are small vessels, very small. You see that this is looking with an endoscope, what the vessel I showed, I think it is 1/4 millimeter in diameter. This is very small. It looks big because of the high magnification of the endoscope. But it's very small perforators. When you compress them, this should not happen. It's not for larger bleedings, of course.
Thank you, Henry. I have a couple of questions of my own because we finished with the questions there. Do you use neuronavigation, and how important is it in certain endoscopic cases?
Yeah, we always discuss it at the courses, and there are many people, they say it's a standard even for ETV. I must say I have not used it for ETV when I have large ventricles, because I think it's possible to puncture it. But we had also a case in our department where the tract goes to the basal ganglia, and then you must say this should not happen if you have used the neuronavigation. So I accept completely when people say you should use always navigation. I use it not for standard ETV, but when you want to make a colloid cyst approach, I want to slide just over the head of the colloid nucleus, come from far laterally, far anteriorly. I always take neuronavigation. Also, when it's the approach coming from here or from here in cysts, also always. But for ETV so far, I have not done it, but there are arguments which are in favor of using it in any case, especially when you start. It will help. But you must look at the anatomy. This is very important. Look at the anatomy. Where is the aqueduct? Is it midline? Is it curved? Is it straight? How is the foramen of Monroe? Is it small? And this is very important because the approach must be ideal. Otherwise, you struggle.
Thank you, Henry. Wonderful. One quick question about the Lotta, the small Lotta scope, which was my favorite scope of all time. Is this named after, was it named after your daughter?
Yes.
Wonderful. I have this. A question about the membranes, if I may ask. As you've divided them so beautifully in these videos, and I have to say, not many people have the perhaps the experience and the inclination to do that. But it's wonderful to see it and to do it. Do you think they remain open long term?
If there is flow, I think so. Yes. If there's flow, I think so. So, for example, this one ETV, which was closed frequently, although they opened it widely again and again, was because the membranes were not open. And then you have not the positive flow. This guy had the ETV, I think, 10 years ago, and is still open. Did not close again. So that shows that when the flow is there, positive flow, it should keep it open. Of course, when he has active infection, ventriculitis or meningitis, then of course new membranes can form and close it again, no question. But if this is not the case, I think there's a good chance when you open all these membranes that you have a reliable ETV which is working over a long time.
Wonderful. One question from Harris is there any condition, I suppose, any circumstances in which the procedure should be shifted to an open procedure? When do you decide to say, okay, I'm going to take the scope out and convert?
So this never happens for ETV or aqueductoplasty or stenting or so, never. For tumor resection, of course, sometimes I try to resect with an endoscope, and then you see it's a massive bleeding. I had a case that was bleeding, each bite bleeding. Then I start coagulate, each bite bleeding. Then I think it makes really no sense. I tried the dry field technique, not effective. Then I replace the endoscope and I take these tubes. It's a 12 millimeter Vigor side view tube, and you follow just the track. And then I do it under the microscope by manual technique, where you have bipolar suction and you can do it. So in tumor case, it can happen, and also in some colloid cysts. Sometimes I see it already. I say to the patient, I start with the endoscope, I will look in, but probably I will shift to the tube to remove the colloid cyst.
Wonderful. Henry, we could ask questions all day and night. I thank you again. That was brilliant. I now like to welcome Basil Zabian, a wonderful star in neuroendoscopic techniques, and for him to do his presentation. So, and then afterwards, perhaps could have a joint discussion with both of us. Welcome, Basil. Thank you, Henry.
Thank you, Mansoor. Thank you, Jürgen, Katerina, and Henry. Every time I hear you talk, I learn more and more. So for me, it's less about sharing my experience and more about hearing yours often. I'm going to just share my slides now and have a little chat about certainly my experience of endoscopy for intraventricular pathology. There we are. If you can't see the slides, please let me know. So essentially, it's how far have we come? So I'm a consultant neurosurgeon at King's. I'm a reader at King's College London, and I've been dealing with pediatric and adult neurosurgery for a period of time now, 10 or 11 years. And I've been doing endoscopy probably since I was a registrar. This is my declaration. We run some courses, they're sponsored by industry, but nothing more than that. So the idea of this talk is why really neuroendoscopy, where and how, where we started, where we are now, a little bit about the literature, but not much, some examples, and a little about the future. So why neuroendoscopy? I've used the slide now in a number of presentations, but it's minimally invasive. We all know this. It's improved visualization. The scope, the camera's at the tip, and as soon as you put it inside ventricles, you can see the pathology. You're right up close. Speed of access, of course, especially if it's ventricular, you're in the lateral ventricle in minutes. You can easily confirm you've taken a whole lesion out if the lesion is small. On the other hand, the learning curve is a bit tricky. The length of procedure can be prohibitive at the beginning. Hemostasis is tricky, but you've heard from Professor Schroeder various techniques of stopping bleeding and controlling bleeding. Instrumentation is lagging behind microscopic surgery because a lot of companies don't feel that it's worth their time to invest in it. There's difficulty in confirming gross total resection with really large tumors, or certainly the extent of resection. Gross total should be easy to confirm, but extent of resection when it's not gross total is a little bit more tricky. So where are we now? Am I about to tell you that you should use the endoscope everywhere, or, you know, is it the case that you should use it nowhere? A reality is, like most things, it's somewhere in between. And like a lot of things, it takes a little bit of time for a lot of people to take something up, but then also some will drop off and realize it's not the best way of using it. Don't be scared of thinking outside the box. At the same time, not everything is a nail if you have a hammer. So we have to kind of go a little bit far back and give a bit of recognition to those who allowed us to be where we are now. This is by far not an exhaustive list, but this is one of the first it's a tube with a candle that you put in the middle, and you can look down it, and that was mainly to use it in the larynx, but then was used urologically and gynecologically, and it's Philip Bozzini in 1806. Then one has to recognize Victor de Lespinasse, who I am told, I don't know if he resected, but certainly attempted a resection of a choroid plexus tumor in 1910. Shortly after that, Harvey Cushing, although it was a slightly different approach, but it was through a small corridor to get pituitary tumors. And then Walter Dandy, who very much popularized it a little more than others, although he still said that it's occasional instances where ventriculoscopy may be advisable, but it seems hardly probable that it would be used to remove intraventricular tumors, so on and so forth. This, however, was now quite a few years ago. Now, I can't really give a talk with Professor Schroeder and not include a picture of Professor Schroeder, especially as he developed the Lotta and the Little Lotta, and where we are now is a completely different place, and it's thanks to people like Professor Schroeder, Professor Chinali, and lots of my colleagues who are part of the IFNE, who continuously push endoscopy and allow those of us who have come after to continue pushing in the same way. Where I personally started is this endoscope, which is a disposable Medtronic endoscope. Fair to say that the image was not great, and the only thing you had is a pair of scissors and a pair of graspers. In terms of bipolars, there was something called the ME2, and it worked, but certainly not really to stop the bleeding. It just coagulated a little bit of the tissue, but didn't stop any major bleeding. So in terms of indications, given that we were very limited with instrumentations until recently, really has been an endoscopic third ventriculostomy. And what everyone told you is it's a two-people operation. One person holds a scope, someone else does the balloon dilatation, and if there's bleeding, you keep washing until the bleeding stops, and you may leave an EVD. So this is a typical indication. We talked about scans briefly earlier in Professor Schroeder's talk. I use these two sequences, a T2 cube or a space, depending on what scanner you use, and a CIS or a Fiesta, again, depending on the type of scanner. The CIS shows you a lot of detail. the cube or space shows you flow. So here you can see that there's deranged flow in the anterior aspect of the third ventricle and bulging lamina terminalis and tuber cinereum on the cysts. When you look down after an ETV, you can see that there's a flow void going straight through, and you can correlate it with the hole through the tuber cinereum, and you can see that all the walls of the third ventricle have relaxed. So it's such an accepted way of treating patients that there's even a success score in terms of ETVs. And we know that those who are very young, especially if they've had shunts before, infections, so on, they're less likely to work. Those who are much older and have aqueductal stenosis are much more likely to work. Now, a lot of people have stopped there and said, well, that's it. The endoscope's for this. Everything else needs elegant and sexy microscopic neurosurgery, and therefore we shouldn't really be trying much more. You could just use the endoscope to look around the corner. So where are we now? And is this entirely true, this kind of microscopic way of thinking about things? Where we are is that we have these scopes. You've seen the Lotta and the little Lotta. There is a bit of an issue in terms of CE marking at present, but I'm hoping that this will be addressed so that the rest of us can start using them again. But we also have the Oscilab scopes that are either 6 millimeter in outer diameter or 8.3. The bigger scope allows bimanual manipulation in a slightly easier fashion, but it's more difficult and cumbersome to use. There are some nuances to using them, but we're not going to go into the ins and outs too much. I use a 30-degree scope, an optic for almost everything now, whether it's intraventricular or otherwise, and it really helps because you can look around the corner, but it's not as tricky to use as the 45-degree scope. The instruments that now we have are the bipolars that work really well. And these rotating forceps that allow us to do what now a lot of people call the spaghetti maneuver, which crimps vessels as you're removing tumors. And the sucker, which should be wall mounted. You don't use a syringe in the same way as you don't use a syringe. You don't ask one of your colleagues to sit there with a syringe sucking away when you're doing microscopic surgery. This is more or less a setup that we have. This isn't the theater I use most of the time, but this is one of them. And you have the endoscopic screen as close to the table, and next to it the navigation. I always use navigation, and I feel that it's helped me understand the intraventricular anatomy better, but I make a point. There's an exercise I have with my colleagues, the registrars, the fellows, where I ask them to kind of measure on the MRI and decide exactly where they want to put their hole so that they can get in to do the operation they need to do, and then to check it with the navigation. So again, on the topic of indications, ones that are perhaps more common and agreed upon, again, an aqueduct stenosis, but look, it's not a stenosis, an aqueductal tumor, so it's a blockage with triventricular hydrocephalus. And what we did here is an endoscopic third ventriculostomy using quite bad scopes. But at that stage, I had already started splitting the fissure a little to allow us to stretch the veins backwards and get to the pineal region or the tectal plate region or the aqueduct. This was mainly just opening the space behind the anterior septal vein and pushing on the anterior septal vein backwards so I didn't have too much bleeding, because I was very clear that every time I went in, the bleeding was coming from that corner, the posterior aspect of the foramen. And this is a post-operative image. Of course, this is one that's destined to make it look good. If you look a little bit to the side, you'll see that there's a little bit of residual. We weren't trying to get a complete resection. It was a tumor that had grown a little but stopped. I've got to say now I probably wouldn't go in and biopsy. I'd wait, because the vast majority are pilocytic astrocytomas that don't change. So again, on the same topic, these are indications that perhaps are well recognized, although some people may not choose to use endoscopy. But as well as the aqueductal stenosis, if we look at cysts within the ventricular system or paraventricular, I think it's reasonable to go in and fenestrate. I mean, this is a big cella supracella cyst, and these are great because you are provided with this huge space and phenomenal anatomy, which is normally pathological. Pathological in the sense that it's been splayed in a certain way. Now, this is overkill. This is using the invent scope, big channel, and using bimanual manipulation. Was there a need to do that? Probably in retrospect now, I'd use a slightly smaller scope. This is at the beginning of the learning curve. What you see there is the optic nerves, the chiasm, and the tracts, but they're splayed and they're pushed anteriorly, so it's not how you'd expect them to look. Then the fourth nerves, the third nerves, and then you have to fenestrate the inferior aspect of the cyst. Now, how far do you go? I've gone as far as foramen magnum at times, but increasingly I'm thinking that perhaps we give And I'm happy to discuss that with lots of my colleagues, but I think we give Lilliquist membrane a little bit too much credit. I think if Lilliquist is really far down and we're convinced that the fluid is getting to the cistern and then circulating to the arachnoid granulations, I don't think you need to get carried away. For instance, this, perhaps now I would not push as hard. These are the 6 nerves bilaterally, and then you look to the side and you'll see the 5th nerve, you'll see the 7th and 8th, and then it gets quite complicated because it's not really how you normally used to seeing this. And the basal, of course, at the back. So some more indications. This is another patient who came in with headaches with asymmetrical ventricles. Without these MRI scans, without the cyst sequence particularly, I would not have seen that cyst that was straddling the lateral ventricle and the 3rd ventricle. This is a choroid plexus cyst, one that we are told normally occurs in children, neonates. You see that, or even at the fetal stage, you see it. And you don't do anything about it because normally in the atria of the lateral ventricles. In this situation, it caused a blockage at the level of the foramen of Monro. And what you can see there is the cyst, which is pulsating with the flow of fluid. So clearly it was a ball valve mechanism. And what we did is I went in at that stage. I had lots of various tricks up my sleeve, but actually the easiest thing was just bipolar in it, cutting the stalk and just making sure that you don't lose it. And that's a really important point to make. Occasionally with craniopharyngiomas and colloid cysts, I have lost a cyst and I've had to go fishing for it. And one of my colleagues has written a paper that we're hopefully will be publishing soon about fishing for lost colloids. Hopefully we won't make it a habit, but it's something to bear in mind. So again, the same topic, some more indications that aren't too left field, but at the same time, perhaps kind of on the edge. So this is a child where at 36 weeks gestation, I was called to say the patient's got a glioblastoma. Surely this is it. There's nothing more that we can do. What I said at that stage is we'll deliver with it with 36 weeks gestation. We'll do an MRI afterwards, and then we'll deal with it, because sometimes they surprise you even with high-grade tumors in the first year of life, and they survive a lot longer than you would if you were 30, 40, 50, and 60. It turned out to be a hemorrhage with no underlying tumor. There's no vascular malformation. And then we had an encephalomalacic cavity. This grew over time, and the child had hydrocephalus from aqueductal stenosis. So we thought about it long and hard. 2 operations, 1 operation, shunt, no shunt, craniotomy, endoscopy. And we decided to go in from the top, from the left side. There is a little bit of intraventricular tourism that I am slightly apologetic about. So we did look around. When you've got space and you're not causing any trouble, I think it's important to look around and try and learn the anatomy and gauge what's what. And this is the posterior mesial temporal lobe. You can see all the structures that I'm sure epilepsy surgeons who are logged in would be very excited about seeing. Then we look to the other foramen of Monro through the left side. You can see the lamina terminalis, and you can see the tuber cinereum. We make a hole. This is the axiom stellate. This is another reason I use the axiom stellate, although naturally it's a few £100, so I wouldn't only use it to make the hole. But I like it because it's just the right stiffness and the right shape at the tip. Then I use the figure of 8 balloon, and I think it's essential to use it. Although Professor Schroeder showed us some really nice single balloons that inflate slowly, but the ones we have seem to inflate suddenly, except the figure of 8, which does it slowly. And it protects things quite nicely. What you can see there is the pituitary stalk, the pituitary, and the carotid. Now comes the step further, which makes it an ETV plus, which is okay. Well, if we're fenestrating the cyst, well, we're fenestrating it from the other side into this space. Why can't we go from this space and fenestrate it into the cyst? And we had planned it in a way to allow us to do that. The issue with this, and all my colleagues who only do microscopic surgery, because I obviously do a fair amount of microscopic surgery myself, not everything is destined for the endoscope, is they feel that you need to have 2 hands to be able to do something like that. The reality is just because the endoscope overestimates what you're doing, it doesn't overestimate, it shows you what you're doing. You're so close, it becomes quite dramatic. A lot of this is done, but often we don't see it because we're not that close. Our hands are in the way, instruments are in the way, and we pull. And occasionally we have a bit of a vessel pops here and there, and people say, well, I don't know, I was doing exactly what I would normally be doing. So with this, you see a lot more, and often it can look a little bit more dramatic. But you get a lot of tactile feedback, and that's really important. Now, we talked about colloid cysts. This is where we start going into the realm of a lot of people will tell you, no, never endoscopic. Some people will tell you sometimes endoscopic, and other people will tell you always endoscopic. I'm not going to tell you always endoscopic. All I'm going to say is all the ones I've done since I became a consultant, I've managed to take endoscopic. This is a large colloid cyst in a 16-year-old child that came in as an emergency. I personally, the one thing I've become more allergic to is this notion of bilateral EVDs and wait till the morning, or shunt and deal with it later on. Admittedly, it depends. I mean, if there's no one who can do a good operation, then yes, of course, the child needs to stay alive. You don't always have to do 2 EVDs, you can just put 1. In this situation, we knew that the colloid cyst had gone between the 2 leaves of a cavum septum pellucidum, and there was agenesis of the corpus. So, but we had hoped with the consistency of the colloid that we'd be able to go in and do it. This was my first one as a consultant, actually. And what you can see is we used the suction. You can see the bulge just below the fornix, and we buzzed, but immediately the contents come out. So you put a sucker straight away, so you don't end up with this irritation of the CSF and the ventricles that you can get post-operatively. And then you pull, and at that stage, all I could do was pull and twist. We hadn't quite started messing around with the choroid fissure as much. This is back in 2014, 15. And then what we did, once we did that and pulled this side of the colloid cyst out, then we went through the septum pellucidum. We made a whole figure-of-8 balloon, and then went and got the rest of it from there. And then we ended up with a complete resection, no recurrence. Now it's close to 10 years, and the child went home a few days later. He also had sickle cell disease. He'd had a crisis before surgery, but actually was completely fine after. I just said to you guys, you know, is it the case that you do endoscopy for everything? And the answer is no. Why not endoscopy? This is a prime example. A patient like this with an exophytic brainstem tumor. A lot of it is peduncles, but actually a large component of it was pontine going into midbrain. And an operation like this should be in my opinion, in my hands, a telovelar approach where I can sneak up on the tumor and I can have better control and then go in and use monitoring and then take the tumor out. And the endoscope adds nothing other than risk and shows me very little, because once you're inside, you have this kind of Eiffel Tower phenomenon where you're so close you can't see the beauty of the Eiffel Tower. I may have used this analogy once or twice in my life before. Those of you who have heard it, I apologize, but I seem to like it increasingly. So then you see the brainstem and you see the floor of the 4th ventricle. I think the 2 most beautiful parts for me in the brain are the 3rd and 4th ventricles, because of the anatomy and because of the type of pathology you get there, and because they make you work to get there. Here it's quite simple. Once you're inside, the major issue is the monitoring, and you need to have an excellent neuromonitoring team with you and an excellent anesthetist and so on and so forth. And what you can end up with is this picture where you can see on the left side preoperatively and on the right side postoperatively. If one was to put the right bottom hand corner image up, you'd almost be thinking, well, are you lying? Did you take it out? And the reality is, it's important to demonstrate exactly the rest of the scans, because no, we didn't take the whole thing out because we were limited. It was quite a distance, and also we were limited with our monitoring. The patient was fine afterwards. It was the right intervention. The tumor was growing, causing symptoms, and since then we haven't had to do anything else. So to go back to the topic at hand, which is endoscopy, we talked about why not endoscopy. We talked about what kind of indications, even though some of them perhaps a little bit more left field, not a typical ETV. And then the question is, well, hang on, can we take endoscopy to the next level? If you look at what general surgeons, laparoscopic surgeons now are doing, they've taken something where they were told there's no way you will be able to do these kinds of bowel resections, liver surgeries, so on and so forth with endoscopes. And then they actually made it their own specialty because equipment was developed. So the question for me was always, can I get the equipment that I use microscopically down an endoscope? Because then it stops being an issue of, am I an endoscopic or a microscopic surgeon? It's just the question is it a very deep, dark hole? And therefore, do I need to adapt the instrument and have the camera closer? And we found this endoscopic ultrasonic aspirator. You don't need the 3-way tap, because the 3-way tap is to have wash or suction. You only need suction. And we got it and realized it didn't fit down the invent endoscope and it didn't fit down the Lotta. Certainly both scopes are large enough in terms of diameter, but the shoulder of the ultrasonic aspirator was a bit of an issue, so we had to dismantle it and use it that way. We recently published, I've been going on about publishing this paper. It took me something like 8 or 9 years, but we finally got there and we published it. About 58 patients, 58 procedures, 52 patients. This is up to about 3 years ago. A majority had headaches because they had hydrocephalus. And we found it useful in at least over half of the patients, but a lot of them, the sucker was good enough. We managed gross total to near total resection in about 30%. That's because a lot of them were low-grade gliomas, i.e. optic pathway hypothalamic gliomas, craniopharyngiomas where the pendulum has swung, and now a lot of patients are having proton beam therapy or radiotherapy if they're adults. And then the rest were high-grade gliomas. We also, the most common location, I always thought for one reason or another, is lateral ventricles and third, but actually it's third ventricle because it included pineals, thalamic, tectal plate, midbrain, as well as you've heard, the optic pathway hypothalamic gliomas and so on. Lateral was second to that. And 40% we split the choroid fissure to get to the third ventricle, and we'll talk about that. Someone asked earlier about deficits. All the deficits were transient. We had some motor deficits, some ataxia, some memory deficit, but by far the vast majority recovered within days. The rest took weeks. Some took months. The ones that took months were, we've had a patient with a colloisis where introducing the introducer sheath was where the problem was, and there was bruising of the fornix with that. This is why you become quite obsessed about saying, look, again, as Professor Schroeder said, when it's your registrars or fellows or even colleagues who haven't done as many, use the navigation. Not all introducer sheets have numbers on them. The extent of resection was always dependent on location, consistency, histology, as well as instrumentation. But pushing companies to get the right instrumentation is tricky at the best of times, certainly when it's not a specialty that makes a huge amount of money for companies. And this is a little bit of breakdown of some of the other pathology that we dealt with. So recent development by Soaring themselves, the endoscopic ultrasonic aspirator company, is that they've changed the handpiece. They worked with a professor in Charité in Berlin, Ulrich Tamale, but as well as spoken to Professor Schroeder and others in terms of getting their opinion. Some of the modifications we have done is adding this graduated suction piece from the sucker, from the Oscolab sucker, and you can just use it on the ultrasonic aspirator, which means you can get basically 2 birds with 1 stone, although I still would rather use a suction because it's easier to handle. Some more recent developments is this intraoperative neuromonitoring probe that we developed in-house, and this has allowed us in some patients to map and therefore protect eloquent brain. So some examples of the use. This is an 86-year-old lady who hailed from Scotland, swam 4 times a week, and then started becoming a bit unsteady, and her memory wasn't as great as it used to be. And this is the first time the Soaring worked well. You'll see 2 things here. First is how well it's working at bringing the tumor towards us. It's not too vascular. You'll also see that as I look backwards to the back of the third ventricle, that's when I caused the bleeding, which is typical. That's what you expect, which is why we started looking at the choroid fissure, anterior septal vein, and how to manage them best. And then a little bit of a dry field maneuver here as well. And I will fast forward a little bit to show you first the spaghetti maneuver that we were talking about. So you pull and you twist. I didn't twist too much there, which is why there was a tiny little bit of an ooze. But all you need to imagine is the twisting action after that. So this is the back of the third ventricle that we'll be looking at. And you heard from Professor Schroeder, you'll see the pineal recess, you'll see the aqueduct, you'll see a few things until you see nothing, or you see a lot of red, or the Japanese flag, as you put it, Henry, earlier. And then what you do is you suck some of the fluid, and that allows you a little bit more visualization. And that's the optic pathway hypothalamic mixopapillary tumor. A little bit of the bruising of the fornix you could see. There was a question which is, can you bruise one fornix or can you damage one fornix? Try your best not to damage any. Sometimes you have to go back in the other side, so really try not to damage them. But you can handle one fornix with a degree, I wouldn't say impunity, and I don't want to say aggression either, but you can be a bit liberal in handling it, but you need to not damage it, obviously, even though some people will say you can cut one fornix and get away with it. Don't cut a fornix. So what you can see is we de-roofed this tumor and we allowed CSF to flow. The patient didn't need a shunt, and she survived another 3 years and died of unrelated causes. This is the other end of the spectrum, a 2-year-old with what I thought was a choroid plexus papilloma, quite large, 8-9 centimeters. I thought we'd go in, devascularize it, get the pedicle, cut the pedicle, and then it'll just pop out. It wasn't a choroid plexus papilloma. It was actually a meningioma. So we managed to get the stalk, we lifted it up, and then the soring was not working as well. So really in this situation, we did convert, knowing that we would convert, and we used a tubular retractor to take the rest of the tumor out. And this is what it looks like. And even with a tubular retractor, not that much of a tract. This is a thalamic tumor, similar concept. We manage a good debulking with the ultrasonic aspirator. And what I'll do is I'll just move quickly through that, show you the back of the third ventricle, what it looked like at the end when we took it out. We stented the aqueduct because I was convinced that the tumor is going to grow and block the aqueduct. It did grow, but actually we went back in 2 further times. The child survived 24 months. Was intact throughout. Every time he'd deteriorate, we'd operate, he'd be intact, go back to school, spend Christmas at home, so on and so forth, until it got to the end when he then had metastatic disease, and we just called it a day. 2 kind of aspirator alternatives, but they're both debriders, and what they do is they you can see there's a window and there's a cutting device inside, and it keeps rotating. The only thing I would say with that is it's really good. If I had it when I was doing the meningioma, I possibly would have taken it out endoscopically. But the issue is you have to be careful with this. So what I'll show you is as you're using it, you can pull normal tissue inside and it will bite, even though I was being very careful and telling everyone in the room how you should be very careful, but it pulled a bit of the anterior commissure and it bit, and therefore we lost a little bit of it. Of course, the anterior commissure is okay, that's the bit there, but if this was the optic chiasm, that's a different story. So I try and use this only in the lateral ventricles and not near very important structures. So very quickly, we'll just talk about approaches to the third ventricle, because I mentioned this choroid fissure, I mentioned the anterior septal vein. I won't talk about the ins and outs of transphenoidal, terional, subfrontal, so on and so forth, and the posterior approach, which I really like, infratentorial supracerebellar. I'll talk to you about the endoscopic transchoroid. I'll talk to you about why, a little bit of the literature, the anatomy and the technique. Why it's mainly pineal tumors with hydrocephalus, because you saw Professor Schroeder demonstrate beautifully how you'd need 2 burr holes or a trajectory that's suboptimal for either approach, either the ETV or the biopsy, but one that just is good enough for both. And I looked at a lot of high resolution imaging and I thought, well, these tumors are almost in the lateral ventricles. I'm going to go in and see them. Of course, that's the ignorance of youth. And when you go in, you realize they're covered by ependema. So why is anterior third ventricular lesions, middle third ventricular lesions, and posterior third ventricular lesions all benefit from transchoroid approaches depending on the size of the foramen? And I looked in the literature when I was first considering doing this and found that in 1998, Professor Roton had written about cadaveric approaches to the choroid fissure, and then a video which was microscopic in 2005. And then one of my colleagues and friends, Professor Ibanez Botella from Spain, had demonstrated his approach with 7 transventricular transchoroid colloid cysts. Then a few more after that. And then we described our approach in a very minimalist way in this paper on the ultrasonic aspirator, but hopefully we'll be discussing our full data soon in another paper. And we've had 82 procedures up to December last year. We had data for about 40 of them. Gross total resection was possible in all colloid cysts, of course, papillary cranial, some near total resection. The rest were biopsy, debulking, or subtotal resection. No major complications. And we did delayed cognitive testing for a large number of them, but certainly nothing from splitting the fissure specifically. And the other risks that we had, the other complications we had were infections, wound breakdowns, but small numbers, ACSF leak, patient with a weakness of the left arm, probably because of traction of the thalamus, and some double vision and so on. So in terms of the anatomy, you have to coagulate the choroid plexus and you go either tinea fornicis on one side or tinea thalami. And then what you see, if only what you see is this, but what you should see is something along those lines, but you won't, of course, because this is cadaveric. So I'll show you what you see. Certainly the first patient, this is what I saw. I went in, and if you look at the scans there, it looks like in the right ventricle, you should see the this pineal tumor, pineocytoma, in this patient who had to be a PhD in neuroscience. And then I made a mistake of not coagulating the choral plexus and not going lateral enough to find the fornix and reflect it. I made a hole where I thought the tumor was, looked, and I saw a big vein, and I thought, this is not right, and I went through the foramen of Monro. But soon after that, I had another patient, not a tumor. This is an encysted fourth ventricle, needed an aqueductal stent, a revision of the shunt or a ventriculostomy, and I went for a ventriculostomy and a stent. And what we did when we opened is we found that both fornices were stuck to the roof of the third ventricle, and the foramina of Monro had closed bilaterally. So what we did is started dissecting with these blunt dissectors that you get with the endoscopic set. We used the balloon, we dilated, we buzzed a small vein, which should have been a remnant of an anterior septal vein. And then we got access to the third ventricle after cutting that, and we managed to stent. You can see flow beautifully demonstrated through the stent. The stent has got a reservoir to stop it migrating. So then we moved on to anterior third ventricular tumors. And this is a papillary craniopharyngioma. That's the approach, right? Lateral ventricle, anterior septal vein, coagulated cut. And you have this comma-shaped corridor into the third ventricle, and you can take more of the tumor out. A near total resection. The patient was fine for a couple of years and then ended up with progression. So we went for we went for radiotherapy. A 10-year-old progressed despite 3 lines of chemotherapy, optic pathway hypothalamic glioma, already visually impaired, a phenomenal 3-year-old who's been doing voiceovers for cartoons and so on and so forth, very professional, despite her young age. And we did a septum pellucidotomy. You have to do that with anterior third ventricular pathology because the fluid can go to the other side and push the septum onto you. Then we used the monitoring probe there, but it doesn't return anything on the caudate. We lifted the fornix, we buzzed the anterior septal vein, we cut it, and we got a little bit more access to the tumor. We dissected it away from the third ventricle at the top, and then we just de-roofed it. That's all we did. So we got access again to the rear. You could see the habenula commissure, the aqueduct, the posterior commissure, the pineal recess. And this is all we needed to do. And then I thought, well, as long as chemotherapy now, targeted chemotherapy, keeps it stable, then we're done. It turns out that they are far better than we'll ever be once they have a target. That's what you need to give the oncologist, and the tumor almost disappeared. So on the same topic of anterior third ventricle, these are craniopharyngiomas, edemantinomatous at this time. And the idea here is to just decompress, de-roof, and then go for proton beam therapy, although proton beam therapy is not without risks. But certainly with a lot of these, we've avoided hypothalamic damage. We do not have patients who have not started off obese and have become obese later on. You can actually get quite a bit of a near total resection in some of them, but you shouldn't push it at any cost, because if they are really involved in the hypothalamus, you shouldn't really be messing around with that. Now, to go back to the same principle earlier, not everything is endoscopic. Some things are microscopic, but some things are microscopic, and then you go, okay, I'd like to look around the corner, and then you stick an endoscope inside. And this is exactly one of those. So tubular instruments, because you get used to using tubular instruments. This is the Mithaka arm that you heard Professor Schroeder talk about, which I'm sure he's had a hand in developing. It works really well when you need it. I don't normally use it as much. And then what you see is we managed to resect the whole craniopharyngioma, and this patient did not need to have proton beam therapy. And these are the endoscopic pictures at the end with the lamina terminalis and so on. And finally, I think I'm going to just talk about the posterior third ventricle before I kind of close. The anterior split for the fissure for a posterior third ventricular tumor is unnecessary now. I go through the posterior aspect of the fissure, but this is one of the first ones we did. And what you can see is I did the ETV first because I wasn't going to do too much to the tumor. Now I do the ETV last because I don't want too much bleeding to go into the cisterns. You can see that I'm sacrificing the massa intermedia, as Professor Schroeder said, but then realized that I could go either side, so I stopped sacrificing it. If it's really kissing thalami, don't sacrifice the massa intermedia. This is one where a few years down the line, so fast forward, and we do, I'm not operating much quicker. I just did a 4 times speed on the editing. and we lifted the fissure posteriorly. We got all the way up to the anterior aspect, which is basically where the anterior septal vein is. You can see the internal cerebral veins, and everyone will tell you, these are big veins and you're with an endoscope and so on and so forth. But when you go from the posterior aspect, you're going by the great vein of Galen. I mean, you know, it's everything about, even the term is there to instill fear in you. So you have to make sure you've created a good enough corridor. You have to make sure you take it out piecemeal. But with this patient, we manage a good resection in the end, where a few months down the line, this is the tract and the whole tumor's out. I am not saying all pineal tumors will be approached that way. A lot of them we will approach supracerebellar, infratentorial. We will use the endoscope as well as the microscope. You see Rosenthal, you see internal cerebral veins. You also see the internal occipital veins, which a lot of people don't talk to you about. And you're able to tell whether you've taken the whole tumor out or not and what's residual. And I think it's really important to know that pineal tumors are not solely approached with an endoscopic in an endoscopic manner, but not having endoscopic skills does mean that you are limited, certainly when they first present to you. You can see with a part microscopic, part endoscopic approach, you can do a great job. I won't go on into paraventricular lesions because this becomes more brainstem, and sometimes the endoscope is reasonable. I'll just tell you about a little bit in future directions. A laser, Professor Chinali has been using for a very long time. I'm always interested to ask Henry whether he uses it, but I keep forgetting to do so, so maybe he can tell us today. And the robotic, I think, instrumentation, we're still very far from being able to really do anything with it. Where we have gone, so the future for us had become our fetoscopic approaches to neural tube defects, and we managed to use these endoscopic instruments that buzz at the same time. And a relatively new thing for me is just doing degenerative spine with a unilateral biportal endoscopic approach. So again, to close, neuroendoscopy, yes, a lot of people started doing it before most thought that it's possible. A lot of people adopt it later. That's just a diffusion of innovation model, which applies to most new techniques. Thinking outside the box is good. Not everything is a nail. If you have a hammer, it's a huge team that you rely on. Make sure you attend the EANS in Vienna. There's also the EANS in Graz. The IFNE in Graz. And you're always welcome in our courses that we hold once a year. I think I've overrun. I apologize profusely for that, and I'm be happy to take any questions.
Marvelous. Thank you very much, Basil. That was really a wonderful review of so many aspects of neuroendoscopy, particularly taking things further with tumor resections. You're clearly a credit to the marvelous unit in KIGS and British neuroendoscopy and the international field. Really, really wonderful. Thank you for that. There are some questions, if we could get started with those, and perhaps I could put them to you and then invite Henry very shortly to perhaps jointly to answer some of these. You've already touched on this one regarding a question from Dr. Armon about, can unilateral fornix contusion affect the patient? If you could maybe elaborate on that.
I think I'd say exactly as Professor Schroeder said, you need to be very careful. And if you're doing it slowly and gradually and slowly lifting the fornix, same as you would do with a microscopic approach, you shouldn't. The time I have seen it is when an introducer sheath was pushed quite rapidly in. And I remember saying, hang on, just give it 1 second until I scrub and I will be with you in a second. But actually it was continuously pushed. And then when I looked and pulled it back, realized that it was being pushed into fornix and thalamus. It hadn't gone in, but it caused a contusion, and this is the patient that took a few months to recover. So that was from one side, but you could argue that it's contused both sides because of the way it was pushed. So you can see it. I'm not saying you should be very blasé about handling the fornices, but you can handle them endoscopically as long as you're gentle, exactly as Professor Schroeder said, and you don't have as much in the way of cognitive problems.
Can I just ask, can you maybe talk a little bit about how important it is to go in the inferior aspect of the frame and not going to the superior bit? And that's one good technique to avoid the fornix.
Exactly. I think that's, and the contusion I was talking about was anterior. And I think where we're going is posterior and inferior, and you're lifting it up. And at that point, the fornix becomes much more spread out. And when you go and lift it up, it's not as concentrated as it is more anteriorly and superiorly. And most people who go with a very anterior burr hole then go in and put traction on the fornix, which is why then you are more likely, even with a simple ETV, to cause maybe memory problems. But I think if you go more posteriorly and if you're careful, but it does take a little bit of getting used to doing this. So it's not just a matter of, okay, let me go in and just do that. And I think if there's someone who knows how to do it, who can be around when you're doing it, that's probably the best time to do so.
Thank you for that. There's something that crosses my mind, and I just wanted to put this again regarding the anatomy, and perhaps for both you and Henry. There is a variation between the right and left side quite often in the venous anatomy of what's happening at the foramen Monroe. Usually one side is dominant, and Ugo Ture used to talk about this and look at CTVs and decide which way he's going to go in. Do you look at that anatomy when you're deciding about those rare cases where you're going to put endoscopically or go through the lateral to the third ventricle, seeing which side is favorable to go through?
I'll just very briefly answer it and then ask Professor Schroeder for what he does. But I use those cysts and T2 cubes in the coronal section, and I follow the anterior septal vein and see where it crosses, where it goes into the internal cerebral vein. But I also look at the thalamostriate because some of them are very high riding, as I'm sure you've come across. You go in and you see this vein hanging in kind of in the fluid in front of you, and you don't want to lift it off. So absolutely, you kind of look and see which is the foramen that's most amenable to the approach. That's why I don't go only right. I go left or right, and I sometimes go quite posterior.
Thank you. Henry, do you have any comments about that in addition, or about the preference of which side?
Yes, of course. It's very important that you look to the images. And I look here, I have the T2 weighted image, for example, for colloid cysts. I look here, what is the size of the ventricle and also of the foramen here. And then we make this coronal, what Bas said. It's very important to have coronal. And you see here is a very prominent thalamostriate vein. You see this? It's almost covering all the cysts. And you know, there is always only a little space. And when you look in, it's the same. You see the big vein, here's the fornix, and this is a cyst. So you can expect it. So you look just to the MRI, and then you can really predict what you will find.
Marvelous. This will be another bit in the chapter in the book with the eagle's eye. Wonderful, wonderful. Next question is about the dry field technique. Mariam's asking whether the dry field, she's very complimentary about the dry field technique, but she's asking if we suction the CSF, could it cause the ventricular collapse, make it a problem? And would it be impossible to continue the procedure? I'm sure you can elaborate on that.
It depends what is the size of the ventricle. When you have huge ventricles and you take all the CSF, then it's a collapse. If it's more or less a normal size ventricle, then you see a little bit collapsing. That's why after I have hemostasis, I refill it. Except when I switch to the tube and I make microsurgery, then of course the CSF remains out. But it's correct, there is a little bit collapse, but in most cases it's not a big problem.
And just before we leave
people, sorry, with regards to that, people always ask you that when you do the endoscopic approach. And I've had someone very long time ago said it was negligent to suck the CSF out. And you say, but then what do you do when you do microscopic surgery? And I think that conversation finished very quickly because it's the first thing you do. You can't operate with the fluid there. So you suck the CSF out, you do the operation. You end up with collapsed ventricles. You end up with fluid around the brain at the end. So I think the only thing you're doing is taking that technique to the endoscopic approach.
Thank you. That was a very well made point. Excellent. Thank you, Basil. Okay. Regarding this might be perhaps more for yourself, Basil, he said, what's your opinion regarding use of Nyco, Myriad, Artemis, Penumbra? I think it's one of the techniques for, MIS for clot evacuation.
It's the one I showed. Yes, absolutely. No, it's a great question. I think if you've got something really tough, the Penumbra has not been used for tumors. We're looking at doing that very soon with the company, but Nyco Myriad we have, and that's the video I demonstrated where we took a bite of the anterior commissure. I mean, I blame myself entirely, but I was making the point of saying these things, even if you're close and you're not on it, you can still suck a structure into it. And the difference with the soaring is you let go, it stops fragmenting. With the nicomyriad, if it sucks in, it's cut immediately. So as soon as it's in, it's cut. So you got to be careful. If you're bioptic, apparatus, you don't want to use it, or you want to turn it so that the window is facing away.
Thank you. Thank you. Can I just ask 2 or 3 more questions to both of you, just short, sharp, sweet ones about both your presentation? I think it encompasses what we've discussed. We've seen a lot of tracts in the videos and the pictures. Is there any tips you can share with the group how to minimize damage from tract, how to minimize the size of the tract and the problems it can cause with subdurals and all the other stuff? Are there any tips you have to share?
Take the smallest endoscope what you have, which is enough to do the job. Then you have the smallest tract. You see the difference when you take the little lotter and you take the larger lotter or take a tube. There's a big difference, but after 3 months, you see that even if you have a tube, it's really less trauma if it's not much. And of course, you should not make too much sightseeing, looking left, right, and then, of course, you make the tract, when you have a rigid scope, larger.
Henry, regarding that, is there any limitation to how much you can turn a rigid endoscope? I know that, yeah.
It depends from the anatomy. So, for example, when you have a huge ventricle, really huge, and have a small cortical mantle,
yes,
you can look, as Bess has shown you, in all corners. If you have your thick cortical mantle, small ventricle, then you should not do it because then you damage it.
Thank you. Wonderful. A
The best is an arachnoid cyst. In an arachnoid cyst, you can look around a lot.
Thank you. Basil, you showed some great video about fenestration into the cyst, and it's a very nice stent placement and how to anchor it into the reservoir. Do you always put a stent when you've fenestrated cysts? And is there any advice you can share about that?
Not with cysts, no. So cyst, I would often not even leave a reservoir. With an ETV, I always leave a reservoir and a catheter. If I do a foraminoplasty, often the foramen will close again. And unless there are a few where I've opened them and they're completely wide and I haven't had to do anything. But some of them you have to stent the foramen. The aqueduct is very notorious. If you do aqueductoplasties, I think it's more likely to close. And as a result, you end up stenting the aqueduct. These are the times that I normally do it, but it's really fiddly. And, now we used to have the NeuroPen, which Medtronic made, that you can put the endoscope inside the catheter. Now they don't make it, but they have the shuntoscope that Storz make. But again, CE marking is an issue at the moment in MDR.
So question to both of you, since you mentioned aqueductoplasty, because this does come up, and just particularly for the trainees to kind of, with the mental gymnastics, where is the logical argument, the rationale for doing an aqueductoplasty when you can do an ETV? So if you manage to do an ETV or some other bypass, is there ever an argument for doing aqueductoplasty given the risks involved, even just subtle things like double vision and so on?
Insisted fourth ventricles is the only reason. I mean, I would not. So some people talk about stenting ETVs. Some people just talk about going in and operating on the back and forgetting the ETV, just, reopening the aqueduct. I would only do it when there's an enlarging fourth ventricle that's causing symptoms and problems. So yeah, you're very right, because you don't want to, you're essentially in the brainstem. So I'd rather not go there unless I really had to.
Thank you. Henry, any thoughts about that?
Yes, we made an investigation. I was very enthusiastic about aqueductoplasty because it restores physiological CSF flow. You have no basilar artery in there, and you have a nice anatomy. You can go with the flexible scope, and then we make a long-term follow-up, and there was a high rate of reocclusion. Even after 12 years, no infection, nothing, aqueduct got closed. Then it would be the other option to make always a stent, but the stent is a foreign body and ETV does not require a stent. So I think for an aqueductal stenosis, ETV is the best what you can do. Maybe there are rare exceptions when you see the floor is completely filled with membranes, or you have a big basilar artery distorted, which give no space to go there. I have never realized it, but if, let's say this happens, then you make open a membranous aqueductal stenosis to overcome it. But in general, ETV is the best option. And then, as Bas said, for isolated forced ventricle, we always put a stent.
Thank you. Considering the time we've spent, I think this has been brilliant. I just wanted to put one question from the group and then one final question regarding training. This is in the chat section. It's not in the Q&A. Mohammed is asking, can you tell us about your experience in rate-controlled versus manual intraventricular endoscopic irrigation? I think he's referring to...
As in flow or
yeah.
So one of my operations, which took way too long, and it was maybe over 12 hours endoscopic surgery, but then I've done that with microscopic surgery. So here's the disclaimer. Sometimes I am slow. Other times I'm quite quick, but we ended up washing with close to 100 liters of wash. Now, that's not because it's going into the brain and staying in the brain. This is because it's going in very quickly and coming out very quickly into the sucker, because the sucker was on full force, just sucking the tumor out. So with that patient, we were using bags. It's an absolute nightmare, and you swim in wash, and then, you know, if they delay by 2 or 3 minutes between a bag and the other, you can imagine how long that would take. So now, if we're doing big tumor resections, I certainly don't go over 4 to 6 hours, but we use the Belmont infuser, and I use it anything from 20, 30 mils a minute to 150 a minute, but 150 a minute is only through the big channeled endoscope, whilst there's suction going the whole time. So you have to be aware of that the whole time if you're doing it.
Can I ask, what do you use? Use Hartmann's, saline? What do you prefer?
Yeah, Hartmann's or, you know, Ringer's lactate, but I've never seen, I used to do a lot of, you know, testing afterwards and making sure, but it's not like bladder surgery where they end up running into trouble. It goes in and out so quickly, it almost doesn't matter, but I still would rather use something isotonic. And not CSF solution because it's too expensive.
No, I just remember Professor Goodridge quoting Cushing about use of Hartmann's rather than versus normal saline and how toxic it is. But that was very good tips. A question for both of you, if I may, just coming to the end perhaps, and it's been a really fantastic session. And then I'm going to ask Jürgen if he's got anything to ask and add. You've shown some brilliant videos, and we know where technology and advances are going to come and go to some extent. You can see neuronavigation and artificial intelligence coming in. I mean, just kind of connecting neuronavigation to AI and for it to tell you what to do, what not to do. You can see sort of what's going to, you know, your limitations and then eventually robotic surgery, true robotics. What do you say to trainees who are now coming up to beyond level of just competency and safety as a consultant, and they're really keen on developing neuroendoscopic skills? Is it beneficial to really hone in on microsurgery in addition to neuroendoscopy, or is neuroendoscopy going to come into a field of its own, do you think?
Both are very important. So you should be trained nowadays in endoscopy and in microsurgery. It's my opinion. And that's a pity. We started with endoscopy courses in 1997 or 6. We made the first course in Greifswald for the German Society of Neuroendoscopy. Then I saw 10 years, and then it's everywhere standard, like microsurgery, but obviously it's not. And this is surprising. Also in Germany, there are many departments, they don't do much endoscopy, and it's so helpful. That is really surprising for me why this is not well established. But I think it's a matter of teaching. When you don't teach it as a chairman, then it's difficult that it gets established in your department. But I think both are important. And when you say microsurgery or endoscopic surgery, is also the handling. Is traction, counter traction, the same gentle traction handling like you have in microsurgery. So we would say it is microscopic microsurgery or endoscopic microsurgery, but it's microsurgery.
Wonderful. Basil?
Oh, absolutely. I couldn't agree more. I think some people will have the skill set to do certain operations, and others will have skill sets for other operations. That's why one of the reasons people subspecialize. Also, they have the certain attitudes and personalities that bit more relevant to vascular or functional or epilepsy and so on. Put all that aside. When you're training, I think if you are not learning endoscopic neurosurgery, you're not learning the whole neurosurgery, because endoscopic neurosurgery means you learn CSF disorders as well. And I'm conscious of the fact Jürgen is here and he's chairing the CSF section that you have fought so hard for. And the reality is, so much of what we do also affects CSF or is related to CSF. We can't not understand it. So I think endoscopy is definitely a skill that they need to pick up from when they're registrars, in addition to the microscope, and not think that they are mutually exclusive. And then later they can say, look, I'm much better at the microscope when they're consultants, and they decide to do that. But then don't manage intraventricular tumors if you can't use the endoscope. Don't manage pineal tumors if you can't use the endoscope. And be open-minded. If someone else can do it in a minimally invasive way and cause less damage, maybe they should be doing that operation, as long as they cause less damage and actually do the operation.
Wonderful. Before I hand over to Jürgen, I know there's still more questions. Maybe Jürgen wants to put one more question to the team, but I have to say I'm learned a huge amount, and I'm truly humbled by the two of the world's experts here discussing and sharing experiences and educating us. Thank you both. Thank you, Basil. Thank you, Henry. It's been a pleasure. I'm going to hand over to Jürgen. Thank you. Thank you.
Mansoor.
This was wonderful. This was really exceptional. Exceptional talks, exceptional presentations, videos, and also the philosophy behind it, and your humble conclusion, and to combine both, this is exceptional. And also, thank you so much, Mansoor, for your brilliant moderation and keeping the discussion alive. I enjoyed this very, very much. Just one thing, I got very excited when you're talking about CSF and membranes, and I completely agree that, like, I think it was Professor Schroeder's, and Basil, you will agree that opening these membranes is key, is really key. The membranes are so important in the CSF structure, and flow, only when flow is allowed to flow, then the opening will stay open, no matter how the original opening of just one layer was. You have to take care of all the layers, all the membranes. And I have tons of questions, but the end was so brilliant. Also, the summary that you need to do, the pushing and pulling, is no matter whether you use a microscope or the endoscope, that's what you're doing. And please use both techniques to have the best and gentlest and most efficient way to reduce or to do functional waste. So thank you from my side. Thank you so much from the CSF section. This was exceptionally good. And I would like to remind all of you to attend the EANS annual meeting this year. We have a ton of abstracts. It will be a wonderful meeting. Hope to see you soon. Thanks again from my side and from the EANS and the CSF section. Wonderful.
Thank you, team.
Thank you. Nice to see you. Wish you a nice evening.
Same to you.
Pleasure to keep in touch.
Thank you, team. God bless.
Bye.
Bye-bye. Bye-bye.